So good morning, everyone, and I would like to thank you for the invitation to share the week 96 results of the CHAPTERS 4 trial on behalf of the team. So just as a background, the options for and formulations for second-line ART for children living with HIV tend to be limited, with boosted lopinavir having to be taken twice daily, and there being very minimal data on the use of TAF in children. So in the CHAPTERS 4 clinical trial, we were evaluating the long-term outcomes of children who were switching from first-line NNRTI-based to second-line ART, and they would be switching that to an NRTI backbone and also to anchor drugs. The next slide is showing us the CHAPTERS 4 design and drugs. So this was a factorial 4x2 open label trial where we were looking at the first randomization was NRTI backbone, TAF FTC taken once daily, or the standard of care which consisted of abacavir zidovudine with lamivudine. And the second randomization was to the 4 anchor drugs, which included once daily dolutegravir, boosted darunavir, atazanavir, and lopinavir, which was taken twice daily. And all the doses in this trial were according to WHO weight bands. We also had inbuilt PK and toxicity sub-studies. So in terms of our hypothesis and methods, our primary endpoint was viral loads below 400 copies at week 96. And we had 4 main hypotheses. So the first one was that a combination of TAF and FTC would be non-inferior to the standard of care by a 10% margin. The second hypothesis was that boosted ritonavir would be non-inferior to boosted lopinavir by a 12% margin. The third was that boosted darunavir would be superior to lopinavir, ritonavir, and atazanavir, ritonavir arms combined. And the last hypothesis was that dolutegravir would be superior to lopinavir, ritonavir, and boosted atazanavir arms combined. The primary analysis was intention to treat. Looking at the sites and population, the CHAPTERS 4 study took place in 3 countries, and we had 6 sites. And in terms of our baseline population characteristics, most of the participants were male with a median age of 10. Most of our participants had early stage disease by WHO, and we had a CD4 count of about nearly 700 and just below 20,000 viral load copies. Most of our children were also moderately malnourished. And our children had received mostly an efavirenz-based ART and had been on ART for about 5.6 years. We had very good follow-up in CHAPTERS 4. 99% of the visits were completed, and only 11 participants were lost to follow-up. And just to remind us that part of that follow-up was during the COVID pandemic. Please don't take pictures. Thank you. So looking at apologies for that. Looking at the results now, I'm going to look at viral load below 400 copies per mil. Pleased to tell you that we had more than 80% viral load suppression, which was quite high across all the arms. And this was for the NRTI backbone. This was more for TAF compared to the standard of care. And for the anchor drugs, this was more for dolutegravir. The next slide will show us the comparison for the NRTIs. So TAF was definitely significantly superior to the standard of care, and you can see the other percentages for the boosted PIs compared to dolutegravir. And then we also looked at the other viral load endpoints, and what we found was that the effect was similar, with a viral load endpoint of below 60 and below 1,000 copies per mil. And the same applied to viral loads even at week 144. We now look at the change in CD4 count, and what we found was that the CD4 count increased in all arms, and there was no evidence of a CD4 count difference between the NRTIs or the anchor drug randomizations. Sorry, how do I go back? All right. Moving on to the adverse effects, and I'm going to look at the NRTI backbone first. So when we look at the NRTI backbone, what we find was that we had low rates of adverse events, and there was no evidence of any difference between the standard of care as well as TAF. Of note is that we only had one death in the trial, which was also not treatment related. Moving on to the DEXA scans, we did some DEXA scans on a subset of the population, and looking at the NRTI backbone, there was no evidence of a difference in the lumbar total scans. And then when we looked at the total body bone mineral density minus the head, we found that there was a greater increase in bone mineral density for the children who were on TAF compared to standard of care, although there was no evidence of difference when you looked at the Z-scores. Moving on to the adverse effects of the anchor drugs, we found out again that we didn't have many adverse events, but the grade 3 and 4 adverse events that we had were mainly hyperbilirubinemia, which occurred more for atazanavir compared to lopinavir-ritonavir. And there was no evidence of difference for AT-modifying agents or serious adverse events. We also looked at the lipids and compared the anchor drugs. And what we found when we did this analysis was that there was an increase in the total and LDL cholesterol in the boosted lopinavir versus the other arms, and this was significantly so. We then looked at the change in weight and body mass index for age Z scores. And looking at the NRTI backbone first, what we found was that there was an increase in weight up to week 96 of follow-up, and this was highest in the TAF compared to the NRTI backbone, although the difference was a small difference of just 0.8 kilograms. Looking at the change in weight and body mass index for age Z scores for the anchor drugs, there was a definite significant increase in all arms except lopinavir-ritonavir. In fact, what we found for lopinavir-ritonavir was that there was hardly any change in the weight for age and body mass index for age Z scores throughout the 96 weeks of study. We also compared the change in weight for age across the different ART combinations, and it was very reassuring to know that unlike our studies in adults, which have noted that there is an increase in weight for age in those who were dolutegravir, we did not find this in the CHAPTERS 4 trial. So in conclusion, what we can say is that children in the CHAPTERS 4 study did extremely well. We found out that TAF-based regimens were superior to the standard of care abacavir or zidovudine. We also found that dolutegravir-based regimens were superior to standard of care PI-based regimens, and they also had a favorable safety profile. Atazanavir-based regimens were as good as boosted lopinavir-based regimens. Looking at boosted darunavir, we found out that boosted darunavir regimens were as good as, and also showed a trend towards being superior to other PI-based regimens. Children on the currently used boosted lopinavir had the poorest weight gain and least favorable lipid profiles. So when we look at this, we find that our findings are in agreement with the current WHO guidelines of recommending dolutegravir for second-line ART in children who will not have received dolutegravir as first-line ART. And we also recommend that developing child-friendly fixed-dose combinations of tough FTC plus dolutegravir or boosted darunavir or boosted atazanavir would go a long way in increasing access to safety and effective second-line ART options for children. I would like to appreciate our study participants and their families, the site staff, and also the funders of this CHAPTERS 4 study. And thank you to everyone for listening.